point, we'll call to order the meeting of the North Broward Hospital District June Board of Commissioners meeting. Let's have a call to order, please. I'm sorry, roll call, please.
Yes, sir. Chairman Klein?
Here.
Commissioner Uri?
Here.
Commissioner Wellens?
Here.
Commissioner Gregoire? Here. Commissioner Berry?
Here. Okay, pledge of allegiance, Commissioner Berry, please.
Pledge allegiance to the flag of the United States of America, and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
All right, thank you. At this point, the June board meeting had to be deferred to today due to a lack of a quorum among the commissioners for June. So what we're going to propose is that everything that was on the June agenda be deferred to the July agenda for the board meeting of the July board. Is there a motion to defer the items listed on the June board meeting agenda?
So moved. Second.
Is there any discussion on the motion? If not, all those in favor, please say aye.
Aye.
Any opposed? Motion carries. The items from the June board meeting are deferred. At this point, I'll take a motion to adjourn the June board meeting.
So moved. Second.
All in favor?
Aye.
Okay. Meeting's adjourned. At this point, I will open the meeting of the July board meeting of the Board of Commissioners of the North Broward Hospital District. Let's have a roll call, please.
Chairman Klein?
Here.
Commissioner Uri?
Here.
Commissioner Wellens?
Here.
Commissioner Gregoire? Here. Commissioner Berry?
Here.
Okay, let's move to approval of the minutes. Well, I think public comments are listed second, but I think public comments should be first. Are there any comments from the public?
There are none.
Okay. We'll move on to approval of the minutes of the May 30th board meeting. Those are attached to tab 1 to the board materials. Are there any questions concerning the minutes or any discussion on the minutes as presented? Hearing none, I'll entertain a motion to approve those minutes.
So moved.
Second. Any discussion on the motion? All those in favor of the motion, please say aye.
Aye.
Any opposed? Our motion carries. Minutes are approved from the May 30th board meeting. At this point, we're going to be conducting interviews for the two outside board members for the audit committee. The audit committee is a committee of the Board of Commissioners, and pursuant to our rules and bylaws, we have two outside independent members. We've been attempting to schedule interviews with those, with the two finalists for that position. We do have those two finalists here today, I understand. We're going to proceed to interview each of those. And as everyone here knows, whenever two or more commissioners are discussing commission business, it needs to be done in public. That's why when we're interviewing the audit candidates, that has to be done here in public as well. So at this point, I'd like to ask that Mr. James Penkus step up to the podium. And if Mr. Scott Porter is in the room, ask that he remove himself to the secondary room. Okay, thank you. Good afternoon, Mr. Penkus.
Good afternoon.
Thank you for joining us.
Oh, glad to be here.
Again.
No worries.
Okay, at this point, if you'd like to make any opening remarks, I'd like to give you that opportunity.
My only opening remarks are, I'm a retired hospital executive, effectively, and I'm sort of in give back mode. And I used to be the chief financial officer of all of HCA's hospitals here in South Florida. There are 4 in Broward, there were 3 in Dade, 4 in Palm Beach, and so on and so forth. And then I was chief financial officer of HCA National, which was HCA's non-US operations. And I moved back to my place in Miami, and I'm looking to serve. And the North Broward District has a long history and is well established as a leader and safety net provider in Broward County. And I saw you were looking for audit committee members. I'm a CPA as well, and I figured I could help.
Thank you very much. As one of 5 who either volunteered or have been volunteered to serve on this board, we appreciate your service and willingness to serve. At this point, I'll open up the floor to questions from the commissioners. Are there questions from
What years did you work for HCA?
I worked for HCA from 1992 and full-time through 2012. Then I did part-time work for HCA up until January 2017.
Was your direct report to Michael Joseph?
No, Mike, when I was the chief financial officer in Broward County, Michael Joseph was the CEO of Westside Hospital, and then later he was the CEO of Cedars Medical Center. And so no, he was one of our hospital CEOs when I was running this division.
Are you currently reside in Dade County, Miami-Dade County?
Yes, ma'am.
What makes you want to make the trip to Broward County, which
Well, I made
is
the
bad
trip.
on the best of days?
I made the trip to Broward County every day for 8 years.
So it's the same as you've got.
It's right. It doesn't bother me in the slightest.
Thank you.
There's no questions? Is there anything that you're currently undertaking in your role as an independent consultant that could be read as conflicting in any way with your job as independent outside auditor for our committee?
No, but not as an independent consultant, but my status has changed within the last 2 weeks. And some people I know have sort of lured me out of retirement, and I've become chief financial officer of the Miami Beach Community Health Center, which is a 501c3 federally qualified health center that provides primary care, lab, and pharmacy services to the HIV-infected population, the uninsured, and the Medicaid population of North Miami, Miami Beach. We're about an $80 million a year operation. We have 50,000 patients, and it's much smaller than I'm used to doing, but once again I'm in give back mode. And this is an underserved population that needs help really bad, and this is an organization that does fantastic work.
Is that in a uncompensated or compensated?
It's a compensated position.
Do you see any conflict between that and what you would be doing here?
I don't. That's why I didn't remove myself from contention here. I'd still very much like to serve the North Broward District. I don't see any conflict there. Miami Beach Community Health Center is, like I said, it's a nonprofit. It's funded through grants, and it's funded through the Ryan White HIV program, and that's the kind of work that we do. So I personally don't see any conflict. I will leave it to you to decide whether or not I'm right or wrong.
We do have a pretty significant Ryan White grant at our CTTC facility, and I'm wondering if that would cause any issues where you may have to recuse yourself from anything either here or where you're at by purpose of serving on this board. I'm not sure it's.
I wouldn't think so. Our Ryan White grant is Dade County. I don't think it has anything to do with Broward County whatsoever.
Excuse me, Commissioner, I don't think this was vetted through the ethics. I don't know if Nick is here, right, because the conflicts or potential have to be vetted. But since this is so new, I don't know that it would have been, I don't know if Nick is here to opine.
So perhaps with an opinion as to any potential ethical issues, we could proceed contingent upon that evaluation being done. Or obviously an interview being conducted, we can obviously proceed at a subsequent board meeting. Why don't we proceed with some other questions? Is there additional detail, General Counsel, that we're going to need from Mr. Pettis relative to this position?
You know, I really defer that to the ethics officer who does the vetting of all of the information on the forms that were filled out. And since this is so new, I don't know whether or not he would have vetted that part of it to see if there were actual or potential conflicts.
So I guess my question I have is, have you done any recent work with any organizations or with anybody in our facility, in our system that may cause any potential? So you have no relationship, nothing that's going to prevent you in the future if you were to be put on this committee and have to recuse yourself down the road because of something?
There's nothing that I can see that I would have to accuse myself. I have no dealings with any of the North Broward hospitals or any aspect of the North Broward Hospital District.
Okay, so when's the last time you were actively employed in, say, Florida, as a CPA or in a hospital?
2007.
Okay. And from then till now, you've been doing,
I moved to the United Kingdom,
okay.
and I was over there full-time and part-time up until the end of until the beginning of 2017. And then I've done a project here and a project there, but nothing that has anything to do with the North Broward district. I've been effectively retired.
Can I ask an audience member a question? It's about the competition part? John?
I guess that would be.
Well, I think that would come up, I mean, I defer to the board, so that was Chair Pedoli, but I would think it would be part of the ethics
Just make
review
sure
and the
if you-
potential conflicts.
If you would make sure ethics looks to see if it's competitive with the CCA.
Sure. I think it's a good point.
I commend you for taking the role in Miami Beach. I think it's amazing work, and I know it's an opportunity to give something back, but it is your time, and whether it was compensated or uncompensated, it's pretty important work, and
Well,
it's an underserved community.
It's not about the compensation. I mean, the compensation isn't even close to what I'm used to.
Right.
But that's not where I am in my life.
Well, I commend you for it. I think it's honorable that you're willing to do that and working in an area where we need so much help, particularly in South Florida. So I hope that doesn't present a problem with us.
I hope it doesn't. I will tell you, I've only been there a couple of weeks. It's extremely rewarding work. We employ about 40 or 50 primary care physicians, and we run a pharmacy and a lab. And 60% of the patients pay us nothing. So we've got to get grant money and what little, we're a hand-to-mouth organization.
How did you hear about this position?
This position? I'm trying to think. It's been so long.
It's been so long now.
Right. I honestly think it was something that came across my email from somebody I think that knew the prior knew one of the people that used to be on the audit committee that stepped down, and said he knew that person, and then he said, "Mike, you think?" And then I went on your website, and it was in there as we need, so I applied.
I certainly thank you for the interest in allowing us to serve.
I've got I'm very familiar with the North Broward District. I ran a lot of hospitals in Broward County, and I've got a lot of respect for the North Broward Hospital District. It's done great work for many decades.
If you think this current role that you're in pays less than you're used to, wait till you see what this role pays,
No, this is-
even less. No,
This is a concept, yeah, right. I'm very serious when I say that compensation isn't where I am in my life. And
I got you. I think that's honorable. I was just making a joke about that. This is a non-paid position. It takes a fair amount of work. It is an issue that, people are asking people to come and volunteer their time. But, somebody lives out of the district, significant drive. It's certainly a question as to why somebody want to do this.
But I'm a CPA. I'm a hospital operator for 25 years. My experience fits, I believe, exactly what you're looking for. But like I said, I will leave it to you all to decide.
Okay.
Any other questions, anyone? Chairman? Any other questions?
Are there any other questions, Mr. Peckus?
I would move that we confirm Mr. Peckus as filling one of the independent auditor seats on the audit committee.
Subject to,
Subject to the updated ethics review.
motion's been made, is there a second?
Second.
Okay, any discussion on the motion? Okay, seeing here, no discussion, all those in favor, please say aye.
Aye.
Opposed? Motion carries, thank you, sir.
Mr. Pettis, I just recommend you try to get with Nick's team and get that ethics information so we can get you cleared as quick as possible.
Point me towards Nick.
Straight in the back.
Got it. I'll take care of that immediately.
Thank you, sir.
Thank you, sir.
Thank you, ladies and gentlemen.
Thank you.
point, I'd like to call Mr. Scott Porter. See you in the other room. Good afternoon, Mr. Porter.
Good afternoon.
Good to see you again. Thank you for taking the time to come work with me once again. I'd like to give you the opportunity to introduce yourself, give a quick background, anything else you'd like to say in terms of introductory remarks.
Sure, Scott Porter. I am a Florida CPA. I have actually been in practice for 40 years. This is my 40th anniversary in 2018. I started my career actually with a local firm in West Palm Beach, Carpenter Mann Bremer. That firm in 1979 merged into Ernst & Young, and I spent 10 years at Ernst & Young, rising to the senior manager level. And then in October of 1989, there were a group of 5 senior managers who left and started the firm that we have today. So, over the course of my career, I practiced primarily in a mix of local government, not-for-profit organizations, and small business enterprises. And the small business piece covers everything from construction to healthcare to a variety of different industries, banking, those type of things. Pretty varied career. I've also spent a significant amount of time volunteering, both on the Palm Beach County Internal Audit Committee as one of 2 independent members, and as well as for the Healthcare District of Palm Beach County, where for 8 years I had the roles both of chair, vice chair, and secretary, and then after 8 years was term limited out, which was good. So, with that, I'll turn it over to you.
Thank you, sir. At this point, I'll open the floor up to questions. Mr. Porter? I guess the initial question I have, Mr. Porter, is there anything that you're currently undertaking, or that your firm is currently undertaking, which would be a potential conflict with your role as an outside auditor, or outside member of our audit committee?
No, not to my knowledge. We have no business interests with the district. The only conceivable conflict, if you want to call it a conflict, that I could foresee would be if perhaps the firm did tax work in which I was not personally involved for someone who was employed or contracted by the district. To my knowledge, that doesn't exist, but it was always a qualifier that I threw out at the healthcare district, so I would do the same here. But to my knowledge, that doesn't exist.
Okay.
And your involvement with the Palm Beach County Healthcare District ended in 2000?
Yes.
Thank you. Was that similar to what you would be doing here? The same kinds of things you had to consider in volunteering there?
Well, at the healthcare district, actually, it was an interesting story. In Palm Beach County, it was created in 1989, and then following integration, primarily as trauma and independent funding for indigent care in the different hospitals around the county. And after about 3 years, they actually were in a very bad financial situation and were contemplating a bankruptcy filing. As a result of that, the governor stepped in and threw out the entire board, and it was reconstituted with 3 members appointed by the governor's office and 3 members appointed by the Palm Beach County Commission and 1 standing member of the health department. I was one of the members appointed by the county commission. There weren't a lot of applicants at that time.
But that district operates completely different
It
than
does.
us. We are a hospital-based taxing district, where that is, today, I believe, still a taxing district that taxes and then follows the patient with the money.
Generally, yes. They do operate the hospital in Belle Glade, which during my tenure we tried to divest ourselves of. Following the time period when I left the board, the subsequent board members decided to invest heavily in that, and they built a new facility.
Mr. Porter, what drew you to North Broward Hospital District? And, I mean, you don't live in the district, you don't work in the district. It seems like a long ways from Palm Beach to here. Like, what would be the interest here? I mean,
Well, from the time I began my career with Ernst, that office really operated on a tri-county basis from Dade, Broward, and Palm Beach, and we interchanged staff pretty frequently. So my engagements went all the way from a few in Dade County, a few more in Broward County, and the majority then in Palm Beach County. So my involvement has really been across all three counties for the span of my career. In our local firm, that is much less than it was with Ernst. As to Broward County, I do have interests here in terms of I am a board member on a foundation that is located in Broward County, actually in Pompano, right across the street from your facility. And so a lot of the charities, a lot of the not-for-profit organizations that foundation deals with are located in Broward County.
so do you see any issues in your firm or anything that could potentially become a conflict for us, or anything you're gonna have to recuse yourself from, or?
I do not.
Okay.
And the same is true of your service to the other board, the non-for-profit board across from us?
Correct. Most of those are small, not-for-profit organizations that deliver services to people in Broward and Palm Beach counties.
This foundation that you make that makes contributions to Broward Health, do you serve on, isn't it, I thought you disclosed there was a foundation that you're on the board of that makes contributions to Broward Health Foundation?
No.
Okay, so that wouldn't affect that at all, okay.
Well, I see you certainly have a long history of public service and community volunteer activities, which is admirable, ranging from HOA president to, which I commiserate with.
Thank you.
To a wide range of activities, so certainly, we appreciate your willingness to serve here. Are there any other questions that we have? Okay, if not, entertain a motion.
I'll move to confirm Mr. Porter as the second and final member of the independent seat on the audit committee.
Second?
Okay, motion was made and seconded. Any discussion on the motion?
I would just add the same caveat, if we could, and then add the same caveat that as long as it goes to the ethics committee.
Okay, to final ethics check, is there a acceptance of that amendment?
I think he had already been vetted before.
Has he already been vetted?
Yeah, he had been vetted. The issue with Mr. Peckus was that there was
Okay.
a new issue.
Then I would draw it.
Okay, all right, so that, the motion stands. Is there any further discussion? All those in favor, please say aye.
Aye.
Opposed? Motion carries. Thank you, sir.
Thank you.
Welcome.
Thank you.
Thanks for your service.
Careful what
In
you
advance.
Thank you.
Seriously, a very important role, and I'm glad we finally got that out of the way. This has been something that's been pending for quite some time, so.
Yeah, about 17 months.
So, I think before my tenure, so, thank God that's out of the way. We have our outside audit committee members, obviously audit being an important component of, our responsibilities, and the chief internal auditor being one of our few direct reports. So, glad that's put to bed. We'll now turn to committee reports, starting with Compliance Committee. Commissioner Greenwald.
Nick, you'll step in and correct me if I'm wrong at all, and I'm gonna summarize what we did. Nick reported to us first that the Compliance Committee has been renamed Compliance and Ethics Committee to comport with the obligations of that committee to not only ensure compliance, but to ensure ethical compliance. He told us that the Executive Compliance Work Group meets on a monthly basis, gave us the outline of the membership of that committee, which is pretty much all the senior administrative staff. They meet monthly, and they are in the process of revising their internal process, and the revision should be going to that committee around July 31st. There was some discussion about former board recommendations for compliance and ethics, and Nick reported that most had been implemented and are being followed now. And he is in the process of creating new procedures for creating compliance policies, because I guess the procedure wasn't as complete and fleshed out as it should be. Last thing he reported on was hotline cases. He and his committee have developed a new form for reporting those. It's now electronic. He's going to bring a copy of that form to the board so we can see what it's like. For each hotline report, 4 to 5 people receive the alert. It's put into the NAVIX system, so it's always available. And the chart that he gave us had 11 categories. From January 1st, 2018 to June 30th, 2018, there were 86 cases reported and 74 closed. From July 1st to date, there were 21 filed and 8 closed. The average closing time is 30 days. We asked as a board that in the future he provide us more specific categories and information on the types of cases and whether those cases are potentially critical cases or involve reportable events, and Nick has agreed to do that. And that's all I have to report on for compliance.
Okay, thank you, Commissioner. And you also have Legal Committee report?
I do. Legal Affairs and Governmental Relations Committee, which is the formal name of the committee, went through a series of contracts that are before this board today on the consent agenda. It's items 4A through 14 in your packets. There was one additional contract on the discussion agenda, and it will be discussed here today, for Envision M-Care, its emergency and urgent care services. And then there were 2 other items on the discussion agenda, which are also on yours, one involving locum tenens expenses and one involving a board liaison position. And then finally, there was discussion and concern about the new EU privacy policies for the general data protection regulations. And Lynn explained to us where we are on that now. It's developing guidelines for us, and we will have presentations on that in the future, I'm sure, and that's it.
Commissioner, I believe Immodal, the agenda item for Immodal, was also asked to be put on discussion agenda as there was a question about the out for convenience.
Oh, I'm sorry, I don't have that.
It's listed here on the consent, but I believe that's a mistake.
Okay, good, thank you. And that's it.
Okay, thank you. The next item is the Building Committee. I'll present that report. The Building Committee held its meeting on July 18th. The main item was approval of an increase in capital expenditure relative to the Sala Foundation Children's Hospital. The long and short of it is that the project had been underway for several years. It had not necessarily been properly budgeted at the time the budgeting was created. So there's we're expecting it right? Get here first and lunch on it. So in essence, you know, as I said before, there are some items that we're coming across as the current board, which require our attention and our cleanup. This happened to be one of them. The foundation, the Sala Foundation Hospital is expansion is going to be a fantastic addition. It is a fantastic addition. This is the next step that has to be done to allow it to reach its full completion. So the board allocated that, the committee rather recommended that the board allocate that funding, and it's before the full board today is under item 14 of our packet. I think that concludes the building agenda. Building committee report rather. Finance committee, Commissioner Berry.
That was at 9 o'clock this morning, and I don't remember what happened. So, yeah.
We've only been here for 7 hours. So.
Yeah, just getting started. So in the finance meeting, we discussed the May financials. our numbers look to continue to move in the right direction. I'm not going to say great, because when you're losing money, it never looks great, but we are moving in the right direction. We discussed them thoroughly, I thought. I thought there was a lot of good questions. We actually took that far longer than we were supposed to. We perused over June, because June was in draft form, and we're waiting to discuss it when it's in final form. We had a map discussion, which is HFMA, the Healthcare Financial Management Association, puts financial metrics out that hospitals should attain in the performance of their revenue cycle, business office, getting the money that they have coming to them. Janice Mitchell, who is the administrative director for business ops, did a presentation on how we are going to try to achieve MAP certification, and that was a good discussion. Lastly, we had George Hernandez that discussed the supply chain and was able to show us about $2 million in savings just by doing things a little better and a little bit more efficiently. So I was very happy to see that, and we applauded him and his team. There were several people that came with him to show what they were doing and to get done for the organization. So that was the extent of that, but I do have two issues outside of that. So I closed finance, but before we go to the next subject, I want to talk about two other items.
Okay, before we get to those, we do have one other committee report that was not on the agenda. So I'd like to entertain a motion to add the HR committee report to the agenda. Is there a motion to that effect?
So moved.
Is there a second?
Second.
All those in favor?
Aye.
I'll ask Commissioner Wellens to give the committee, HR committee report, the HR committee meeting that took place yesterday.
So we held the meeting yesterday. There were 3 items that came up for discussion. Two were more informational purposes, and one was more of a discussion about a policy change. The first was an issue with dealing with our health plan, and we had a presentation from Jennifer Cohen and Alan regarding an RFP to consider changing our third-party administrator for our health benefit plans for all of our employees to Aetna, who was the winning bid. That process will continue. We have some more discussions there before a final decision is made. The second was a market assessment and adjustment phase 2. Gino made a presentation having to do with a certain group of our employees where we're emergency room techs, patient access specialists, medical techs, monitor techs, PCAs, paramedic radiology physicians, and respiratory therapists, and looking at potential market adjustments to salaries to get them in line with what we need to be competitive in the community. That was a process that we're still reviewing, and we'll be coming back to the HR committee and the board down the road if a change can be good. The third item that was up for discussion was a discussion about a policy change that occurred having to do with personal time off for the management team and senior management team. It was a policy that was put in place and changed last year, and there were a number of discussions about that, and one of the items has to do with board reports. So I suggested that we bring board report personal time off back to the HR committee at the next meeting and look at that. The other issue having to deal with the leadership team was more of a decision by the leadership team to make as they reports to the leadership team. So those were the 3 main items that were covered. Nothing was decided upon, so we have some more discussions. We also asked and received a copy of the procurement code today, so we're going to be looking at the procurement code and see if we can make some adjustments to the procurement code to make us more efficient and a better operating facility as it relates to who has the authority to sign and execute agreements. So with that, I'll turn it back to the Chairman.
I'm sorry. I think I asked yesterday at the HR committee to discuss the PTO issue at this meeting, and to have Alan and I go through essentially the same thing. There were 2 missing members yesterday. I think it's important to discuss. I think the only way we're going to discuss it is to discuss it here publicly. I'm not happy about it, but we have to do what we have to do to inform the public, and I would like the opportunity to discuss the PTO issue.
Is there a motion to amend the agenda to include the PTO item?
Would that be a walk-on item? So I'll make them, so you wanna make a motion to walk that item on, Commissioner Berry?
Second.
Okay, motion made and seconded. Is there any discussion on the motion to walk on the item relative to PTO, paid time off? Hearing none, all those in favor?
Aye.
Any opposed? Our motion carries. The item will be added as item 21 under the discussion agenda.
So this issue. Oh, you would add it to the end? All right, that's fine. Then the other item that, earlier, the two items I wanted to add, you dealt with the HR one, that's fine. The other item I would like to add is the IRO report and our strategy for that over the next 30 days. Because I don't see it on the agenda.
And
Unless I
that
miss
would
it.
also be a walk-on? Yes.
Okay, is there a motion to walk onto the agenda the IRO report?
So moved.
Is there a second?
Second.
Is there a discussion on the motion on the IRO report that was just issued earlier this week? Okay, all those in favor, please say aye.
Aye.
Any opposed? All right, so we'll add that as item 22 under the discussion agenda. Okay. Hearing no other motions to walk items onto the agenda, we'll resume with the agenda as written under medical staff facility updates. We're hearing from each of the chiefs of staff or the vice chief of staff, filling in for the chief of staff for each of our 4 hospitals. And as we noted at the last meeting, this is a revision to the board agenda to hear directly from the chiefs of staff so that the board has the benefit of hearing from them concerning issues of concern and also anything that's positive that they want to report directly to the board as well. So I'd like to welcome each of the chiefs, beginning with Broward Health North. Filling in for Dr. Maheshwari.
Yes, thank you. My name is Gary Lair. I'm the Vice Chief of Staff at Broward Health North. I last was here probably close to a year ago. Dr. Maheshwari was on vacation, and a lot of the faces have changed up here, so welcome all of you. You've been here for a while, a lot of you, and we appreciate all that you do, and I know you have a lot of stamina today. You've been here since 9 a.m., so we appreciate that. We also appreciate the chiefs, appreciate the opportunity to speak to you. I think it's a very important part of what we all do, because we're all here for the same reason, that's to take good care of patients. That's the bottom line. So with that said, I do have an issue that I'd like to address. Starting a little historically, I used to have a role at Broward Health North. I was the medical director of surgical care in our cancer center. As you probably know, we used to have a comprehensive cancer center at Broward Health North, which was a multimodality mechanism to take thorough care of patients with cancer. It was affiliated with the American College of Surgeons. There were certain things that had to be, certain standards that had to be adhered to, because there was a certain way to take care of patients with cancer, things that need to be done. So the medical directorship, along with numerous other directorships throughout the 4 hospitals, was terminated about a year ago. I'm not really sure why. I don't know if it was just financial reasons, but there were reasons. A short time after that, our affiliation with the American College of Surgeons was also terminated. So our status as a comprehensive cancer center no longer exists. That happened towards the end of 2017. Just a few months ago, the contract with our medical oncologists who see patients in our cancer center, have been seeing patients there for probably close to 20 years, was not renewed. So there was a group of 4 medical oncologists who would come to the cancer center on a regular basis during the week to see our, not just indigent patients, but also insured patients. Their contract wasn't renewed. So what that means is that a lot of our patients who were treated there either have to go to another physician in the middle of their cancer care, which is very disruptive. You establish a doctor-patient relationship. Patient relies on their physician to take care of them, make the recommendations. You imagine you're in the middle of a 12-month period of chemotherapy, and all of a sudden, now you have to see another doctor. If you were indigent, you had no choice. You had to stay at Broward Health North. If you were lucky enough to have insurance, you could still stay with your doctor and go to their private office. So the inability to secure this group again and have a continued contractual relationship has affected patient care. Our cancer center still exists. It didn't go away. We still see patients there. So I, along with another surgeon, see surgical patients in our cancer center. Indigent, so they've already gone through all the necessary paperwork, they've applied for their tax funds assistance, they've been approved. So about a month ago, I had the opportunity to see a 29-year-old woman in our cancer center, 29. She came to me with a pathology report. She had 2 lesions in her right breast that were biopsied. Both of these lesions are malignant. She has invasive breast cancer, 29 years old. Okay, let that sink in for a second. The standard of care, in my opinion, I think in a lot of other surgeons' opinions, is for this patient to have a bilateral mastectomy and immediate breast reconstruction. So to simplify it, she really needs both her breasts removed, and she should have immediate reconstruction with either what's called a tissue expander or breast implants. The mastectomies are done by the general surgeon. The reconstruction is done by plastic surgeons. That's what I told her the standard of care is. Unfortunately, we don't have a plastic surgeon under contract to be able to see this patient at all. There's no contract for them to see patients in the cancer center. There's no contract for them to see indigent patients in their offices. So I had to tell this 29-year-old girl, who, by the way, whose mother died of breast cancer at age 29, who also has a 2-year-old child at home and is terrified of dying of breast cancer. Told her, well, we can do your mastectomies, but you're gonna have to come up with some other plan for your reconstruction at some point down the road. Well, then I find out that I'm not allowed to do the breast that doesn't have cancer in it because it's not approved as one of the procedures that gets paid for out of PPUC funding. So now I'm stuck with really doing an inefficient operation, but I have no choice. And I have a patient who is afraid of dying, who's terrified that she's gonna get breast cancer in her other breast at some point, and my hands are tied. So I think part of it is a microcosm of our contractual difficulties that we've had for months to over a year of trying to secure contracts with physicians to take care of our patients in all 4 hospitals. And it's also a problem with our antiquated list of procedures that are approved to be covered by PPUC funding. I don't know what the number is, $150 million of taxpayer money goes into our system every year. This is the patient. My God, if there's one patient that deserves that money, this is one. This is it. And I don't know what to do. So I'm not asking for an answer right now, but I hope at some point we can put our collective heads together and try to figure this out.
Your ask is to get you what you need to do the job completely, correct? You want a physician in there that can give you the plastic surgeon, or at least a contract with one. That's really what you're asking. Are there other missing components to what you need to do?
Well, there are materials that would need to be paid for as well. So
Go with that.
The implants or the tissue expanders, and I would need both sides approved.
Is that the PPUC funding
Yes, ma'am.
that could be used to cover that?
Well, it could be, but there
Guidelines.
is a list of procedures that are excluded from PPUC, and we've appealed this before to the director of PPUC, and it's been denied. This isn't a new issue. This has kind of gone on. I haven't had the opportunity to deal with a patient in this position in quite a while, but now it's come up again.
So a practical question. Do we have this service at Broward General? Do we have everything you need at Broward General?
Not that I'm aware of. I don't Gino, do you know?
For outpatient plastic surgeons, we have plastic surgeons, but we don't have, from my understanding, the PPUC utilization review does not include quote-unquote elective plastic surgery. And I believe that may be what the issue is, whether it's elective or not.
We have plastic surgeons at Broward Health North too, but not under contract to provide care.
Now, is this a matter of our policies, or is it governmental policies that are preventing the approval from going through? When you request permission to do this operation, I mean, leaving aside the reconstruction, but at least even the removal, those to me seem to be somewhat distinct. Is that a function of our policies, or is it something, do we know of a government regulation?
I think it's our policies. I don't know if there's a government regulation. I don't think there is. I think whoever the ultimate decision makers are regarding what procedures are allowed and disallowed. But this, I was shown the list of procedures, and this goes back to the early 2000s, and it's antiquated.
The
In other words, it's something we need
PPC
to-
policies are our policies?
Yeah, so I think there's two issues at play. One is, I think I hear what you're saying, is that there is not a plastic surgeon who currently has an outpatient PPUC contract. Is that right?
Or has a contract like I do to see patients in our cancer center.
Right, okay, so
Either one would be great.
so that's one opportunity, and we could explore all the members, both on staff and not on staff, to see if one of them would be interested in accepting a contract.
Or even at least for now, because that's gonna take, no offense, but that's gonna take 6 months to a year. That's historically, that's what's been going on. So is there a way to get a one-time approval for this patient to be taken care of properly?
So that's your ask. That's what you're asking.
That's what I'm asking.
Including removal of the other breast.
Absolutely.
Do we have the authority to do that?
No, not under Stark, it requires a year contract. Although I will say I have been able, and there's probably some members in the audience who have been privy to this, physicians, we have been able to get contracts through in under a week when pressured. We can make that happen. The issue, the secondary issue, which I think we need to consider, is that PPUC operates on a utilization review approval basis, right? So they have to get authorization. I do not believe that that is going to get authorization for the non-malignant breast, because it's going to be considered, and we can change the policy certainly, but it's going to be considered an elective procedure. So at some point, and this is maybe a gray area, but there's a fine line between, are we electively approving indigent facelifts versus what's actually medically necessary? That's where the line falls.
And isn't there a sliding scale of elective? I mean, if one breast is malignant, my daughter just went through this, one breast is malignant, the other one is likely to be malignant before long.
So, yeah, and so that's my point. I think this is a case management policy discussion that can certainly be reviewed. And I mean, on this particular case, given the time sensitivity, we could either look at it afterwards and investigate and see how we can help out, or take board direction, whatever pleases the board.
What time frame do you need something as soon as possible?
She was originally scheduled for surgery this week, but deferred till next week, pending me. I told her I was gonna come talk to the board today.
So I move that Gino fix it.
There's no second to that.
There's a second.
But, I think this highlights an issue not only for this patient, but of our policies. And it sounds like, obviously we need to remedy this situation, we need to find a solution here, but at the same time, we also need to look at our policies to prevent this recurrence. So, thank you for bringing this up. So the question right now, is what's the next step that our team can take to find a solution? I mean, I'm wondering if there's possible grant funding available, is there some other resource that we can look at and might be able to provide funding for this outside of the courses that you've already sought. Sounds like, as Gino has mentioned, it sounds like working with the case management, there might be an opportunity to find a solution. It sounds like you've already exhausted a number of solutions, but how do we help the doctor find one that works? I mean, where can we send Dr. Laird to say, okay, here's who you speak to see if we can find a solution to this?
So I think what it's gonna come down to, I need to do a little bit of investigation. We can work on fixing this individual solution, obviously, but on a go-forward basis, it's gonna be a policy decision. I think what would benefit us and the board would be for us to work with Dr. Tom Ligesi for case management to identify how we arrived at what we consider specialties that are gonna be covered, what's elective versus what's not elective, and then bring that methodology to the board.
Or perhaps, at the very least, it could be on an exception basis. We have a policy right now, and perhaps there's an opportunity to say, absent board approval, this is the policy. So I don't know if that's something that we can look into. But, it's obviously a case-by-case situation. Oftentimes, we don't want to get into the situation where we're running afoul of, the various statutes and regulations that govern us. So just, if we hire a doctor and the doctor's at fair market value plus X, we obviously have a lot of contracting and compliance obligations we need to honor. So I don't want that to get in the way, but it's a way of saying, there's a delicate dance that has to be done to make sure we remain in compliance and we serve the people we need to serve, being in the public entity that we are, under the corporate integrity agreement we are operating under.
Look, if we can't take care of this particular case quickly, if our bureaucracy gets in the way that much, send her somewhere that will. Send her to the South District, send her to White Cross, send her somewhere that'll do it if we're not gonna do it. That is my recommendation.
So I will say that I did check the South District's policy because they have a similar program. It's not PPOC, but part of what they do not include is plastics selectively. So we looked at ours. We actually cover quite a wide array of services through our program. Like I said, this one may be a gray area. I can work with Dr. Laird to see what we can do with this particular patient. Particularly, I'm more concerned with trying to get a plastic surgeon a contract so that in these instances we can help out.
The PPOC policy that we have, it's a policy that we write as an organization, correct?
It's so it's interesting. It's actually handled at the facility levels.
Right.
We have a list of services that are covered, right? Services that we offer, and then it's a matter of authorization. So is it medically necessary or not? That's where the two components fall.
Is there,
And we can change it.
because could the policy provide for an emergency committee to handle one-off cases such as this, where we have a special case, goes to a committee of a few doctors or whatever the case may be, who can look on a one-off case basis and say an exception is warranted, and we create a policy where we can provide an exception.
We actually do have
Extraordinary
that.
circumstances.
It's the appeal process. So if it gets denied through the program, they can appeal. And if it appeals, now that's where I've lost and I don't know how that process works, but I can look at maybe changing that process, because obviously this scenario, I'm sure it was appealed and denied again. And so my point in saying that is that if it was appealed and denied again, maybe it didn't raise to the level of where it should have risen.
And I guess we ought to quickly find out, how long does that appeal process take? Is this something that's done timely and quickly? Can it be done quickly? And if in fact we can make an adjustment to the policy at the facility level to allow for a committee to review it quickly and make an exception decision, we should certainly be looking at that for patient care and quality going forward, but we should do everything we can to try to resolve this issue, because I'm sensitive to the doctor's request there, and I think it's time is of the essence when you're dealing with a 29-year-old. You're not dealing with somebody that's 90 years old, you're dealing with somebody that's got a whole life ahead of her, and we ought to see what we can do as quickly as we can.
What are the legalities of this board addressing this issue right now? Is there some?
It would be operational.
Where does PPOC money come from?
It's a policy decision on how to change the policy. It should be tax money.
So if
the
it comes from
board-
tax money, the board has a lot of authority when it comes to tax money.
Right, so the question was, the particular individual is getting into operations. I think clearly as a board, you could look at the policy and changes to the policy on coverage and one-off exceptions. But on an individual basis, it really is
I'm referring
Gino's.
to addressing this issue now at the board level.
Mhm.
However, the legalese might need to be, and I'm a little sensitive to this. Maybe I just lost my uncle to lung cancer, and he got stuck in that VA bureaucracy, and there was nothing I could even do to help him. So I am a little sad because he was scared every day. He was coughing up blood. I can only
ironic thing is I sent her for an MRI of her breasts, hoping that we would actually see something in the other breast, so we would have a reason that would be accepted. That's crazy.
Mr. Chairman, can I ask a question? Is it possible to suspend this discussion, get a copy of the PPAC policy, see what it would take to create a modification policy allow for an exception, and maybe we can take it up in a few minutes at this meeting?
Could I just ask one question before you suspend? Once you go through the appeal process at the facility, is this the next stop? This is the only other option? And we're helpless to do one patient at a time?
I honestly don't know.
But that is what you do, you appeal.
You said so.
Well, I also involved my CEO at Broward Health North. Granted, it was the beginning of this week, and I know she's exploring options as well, but as of yet, there's been no termination.
So why don't we do this? Administratively, we can certainly override and authorize this. Why don't we just do that? But I do need to work through the plastic surgery situation unless we have an individual willing to do it pro bono.
I can explore that.
I can work on getting a contract pretty quickly. I just don't know what the timeline is on the surgery. And we can authorize this.
Can it be like a one-page simple contract?
Now you're asking for miracles here.
Just I approve on this day.
All right, so Gino, you're saying there is an administrative solution that can.
Yeah, we can override it for sure. We can authorize it.
Okay, and,
We can make it.
and then the second part of it, you're gonna explore further.
We do need to explore that further, yes.
And, obviously, we're meeting, a turnaround before the next board meeting. I think the executive committee can meet between board meetings and take, urgent action, emergency action, is that correct?
I don't think we have,
Yeah.
I don't think we're gonna have that many cases similar to this one that fall into that bucket between now and next month. I mean, this is not an everyday thing.
But if we need to approve that contract, if it's unusual, I mean, to the extent there's some.
I could authorize another one until next month if it
Does the
changes.
standard of care suggest both of these procedures happen at the same time? Or is it just so I
It's
understand?
best if it does, but it doesn't have to be. But I think it's better for the patient, both psychologically and physically.
I wasn't sure if it wasn't supposed to be done at the same time, but I think if what I'm hearing you say.
It should be.
That's ideal.
Yes.
Okay.
Can I
That's
ask,
best practice.
Gino, is this the first you're hearing of this?
On this particular case, yes.
Okay, I trust that Gino will get this resolved, however he needs to get it done. You probably skipped a step, and I appreciate that you brought it to the attention of the board. I am also gonna ask Jennifer Gottlieb, who's in the audience, I want clarification on what interference is from the board level. I do not believe the legislature's intent was to stop us from getting involved in a case like this, which potentially could be a life or death case. I think the legislative intent was for individuals, not to meddle. So I'm going to ask you to ask Senator Farmer if he can get us a clarification on the legislative intent of interference per se, which is recently added, and I believe we're the only hospital district that has that provision in the state. It's an issue I talked about yesterday. That's irritating me a little bit. And when we start talking about somebody whose life's in our hand and we're worried about the politics or the bureaucracy, that's frustrating to me. That's not what I'm here for, and we need to push through that. Seeing that Gino hasn't heard it, I trust Gino will get it done. So I'd like to see that at the next meeting. If it's not, I would appreciate you or whoever from your organization, from your site, coming back and telling us that it did get taken care of. I doubt that you'll be coming back to talk about that. I know that Gino will get it done.
And let's, make a note to add this to our next board agenda, that we get an update on the status of our policies relative to, situations like this. Exceptional and urgent circumstances, in the nature of, some type of appeal process or board approval process. So we can take a further look at it.
Great. Thank you all very much.
You're welcome.
Appreciate it.
Thank you, Doctor. Next we'll call, Dr. Jensen, Broward Health Imperial Point.
We didn't do the credential.
That's after.
Oh, I'm sorry.
I'll be much lighter. Not so much. Imperial Point, just recently, a week ago, we completed the last phase of Joint Commission survey. We had the last hospital go through the survey, did an excellent survey. Our surveyor was very engaged in gave us a lot of good ideas to move forward for some future changes. We had a very good interchange during the chief's meeting with the surveyor, who was an anesthesiologist, and with some of the higher academic institutions from the Northeast. So I was able to query him on some ideas that we wanted to do for our paired physician policy. We're going to move forward with these ideas through our chief's meeting and getting all 4 facilities engaged, and perhaps even investigating having a new committee that we do at the physician level that vets impaired physicians and how we can address these issues. So we will be bringing these forth to the board. Commissioner Klein was kind enough to meet with us earlier today for a few minutes, and we appreciate the ability to have any of the commissioners, especially ones that are affiliated with our hospitals, to come and any of the community relations, come talk to me, come to our med exec committees if you want to have any other information that's going on locally at our hospital. We try to make sure that we run our med execs as a global system. We are a Broward Health system, hence why our chiefs meetings are an important portion of our monthly meetings to engage with our other colleagues in making sure that we're doing excellent patient care. And unfortunately, we do have to manage and administer for problem physicians. So we will take that duty very strongly and make sure that we're on the cutting edge of making sure that we're looking for, we like to say, don't wait for the train to fall off the track before you fix the tracks. We want to look at physicians that perhaps need some help. Some of the things we talked about was physician burnout, even at the residency level. And if we do have a teaching program, and we need to be addressing not only those physicians who are not quote-unquote staff members, but still members of our Broward Health community, and looking for those issues with physician burnout, and what do we need to do as a system to help our physicians through these times. So we'll be bringing those ideas forward probably in the next few months. Found out I misunderstood. We're moving forward to vote for using capital funds for doing dictation into the system for progress notes that we're trying to get implemented before the end of the year. I wish the commissioners would support that aspect so we're going to eliminate paper charts in the hospital system and go to that communication devices that physicians get engaged with. So I wish you would approve that funding to make sure that we do get that system on board. And the faster we get it on board, the better off we're going to be able to do appropriate utilization in our system.
That's a modal exhibit.
Yes,
Yeah.
absolutely. Item 11 on the consent agenda. Thank you, Dr. Jensen, and your colleagues for having me at the Chiefs meeting. I enjoyed the dialogue. I look forward to attending further meetings. I encourage my fellow commissioners to one-on-one or one at a time to do the same. In addition to the M-modal dictation program being an improvement, it also is a cost saving. So it's a win-win situation there.
Yeah. So we look forward to having that system and engaging our physicians and working with them to get us to that next level of patient care and utilization improvement in that system. All right? Thank you for your time.
Thank you, Doctor. Now I'd like to ask Dr. Gingaro from Broward Health Coral Springs.
Good evening, Mr. Chairman, Commissioners. Welcome, Mr. Barrett, Commissioner. We also had JACO survey, which we did very well, and I want to give kudos to our new administrative, I don't know, are they here? Yes, Jared Smith and his administrative team. The fact that he just came on board in January and we had joint commission a couple of months later is a real testimony to what he's doing out there in Coral Springs. And I want to thank the leadership team, especially for our new leadership team, because my first 2.5 years as chief, and I guess now I'm the grandfather of the 4. So I've been here the longest without rerun, Dr. Jensen. But I want to thank the leadership team for providing new leadership at Coral Springs, and we are excited and we're happy and we're communicating and we're working collaboratively with our new team. Open door policy, dialogue back and forth, much improved. So thank you, Jared, and your team. And we are now going to be having an opening of our new labor and delivery tower on August 16th. The ribbon cutting ceremony is at, I think it was moved to 5:30. around 6 o'clock, so please come on out to Coral Springs. So we're excited about that. The only thing we're not excited about, and I'm sorry to have to bring a negative, and I won't go into detail, is our contractual processes that are going on. I think that we're trying to get new physicians on board to take care of patients for service lines that are needed, increase patient care, committee attendances, and we're being told at the medical leadership level that, well, we're still waiting to hear from corporate, and not throwing anybody under the bus, but it's going towards compliance, legal, and then it's FMV, compliance, legal. So we're going around in circles. We have a surgeon that needs to get on staff, 1 year waiting for a contract. So I'll leave it at that. I'm not going to get into any other contractual issues, but please try to address the contractual process so we can get some care for patients out there. Thank you.
Thank you, Dr. Gingaro. And just to follow up on 2 items, I think at least a couple of us have done a tour of the new tower. It's going to be open at Broward Health Coral Springs. It's a significant addition. It's a beautiful addition. It's going to increase the capacity there tremendously. So I'm very much looking forward to that ribbon cutting. There's also a new piece of equipment at that facility on which there was a ribbon cutting a couple months ago. I understand it's only the 3rd one in America of its kind, the 1st one in Florida. So it's great to see Broward Health being on the cutting edge of getting this new equipment. And just also want to commend Darren Smith, the new CEO, doing a fantastic job at Broward Health Coral Springs. And we'll move on now to Broward Health Medical Center. Dr. Morrison.
Commissioner Klein, do you mind if I just say, as usual, I always have to find money, so the foundation, I just talked to the foundation, and they're going to be able to help pay for that patient, so we're going to be working on that.
Look at that, you cut through the bureaucracy just like that, wow.
As long as it's compliant and legal, just want to make sure, that's what I do, I find money.
Perfect.
Chairman Klein, Commissioners, Council, C-Suite. Thanks once more for speaking to you as a group. I bring some good news from Broward Health North as it relates to a recent award we received from the American Heart Association and the American Stroke Association. This was an award that recognized our commitment to providing, appropriate care for our stroke patients, as well as that we follow all the latest guidelines, latest scientific evidence, and everything. So as a stroke center, we continue to be one of the preeminent ones in our community. So, thanks for your leadership there. It should be mentioned that whereas Dr. Zingaro has a new CEO, we're still in the process of looking for one. And through, you smile, but it should be mentioned that we have now, it would represent our 4th over the last 3 years, having an acting and one as an interim. So having said that, I must also recognize that having Mr. Santorio there is truly a blessing. And as it relates to filling some of our product lines or trying to close gaps in our coverage, he affords us the opportunity of sometimes providing care to our community. Having said that, I must bring to fore as well what has been mentioned before, that whereas he can be incredibly efficient in turning over these contracts, getting things done, we still seem to have some bottlenecks, which I think as a group we will be able to solve it. I will just cite one, I think, to give you some sense for what goes on at our institution. We have a residency program for which we really pour a lot into those young physicians. And as such, having spent a lot of money and that's one of the things Mr. Santorio is doing, he's actually looking at we're going to have somebody come to review our residency program, see what works, what is efficient. And overall, I think it will give us a good return on our investment. Having said that, I want to make you all realize that we continue to train our young physicians to go out into our community, and they do go out into the community, which I'm thankful for. Unfortunately though, the community they go to Holy Cross, they go to health, what I call it, South Broward, they go into Baptist. We have to find a way to keep these young physicians who want to stay in our district here. I think this is one more thing that I'd like to put for Mr. Santorio to solve, because I think if anybody can do it, he can. So without anything more to say, I thank you for your leadership, sir, and I'm convinced that you will solve this problem too.
Thank you, Dr. Morrison. And I have to say that one is actually easy because Dr. Ta and Beth Cherry own that, and they are the reasons why we're getting the people in for GME and moving things forward, and they have already started to meet with residents to hire people, and I am very confident that they'll make that happen. So, good
You're not
things.
passing it on, are you?
No.
Okay, thank you again.
Thank you.
Thank you, Doctor. And, and when we talk about the new Broward Health, I mean, it's no joke. I mean, we have an almost new board, we have a new executive team, we have new CEOs at the hospitals, obviously an interim one at Broward Health Medical Center. We have Alice Taylor, Jonathan Watkins, Jared Smith at 3 of our 4 hospitals who are all doing fantastic work. So as we continue to retool and rebuild, the public is seeing this. I attended a legislative reception last week and a lot of positive response from those with whom I interacted. So clearly we're heading in the right direction. We need to keep moving forward and let's get the best new hires we can. I don't think we want to lose Gino to take over as CEO of medical centers. I know that's a search is underway, but wherever possible, we're upgrading, right? And that's what we need to keep doing. So, personnel, equipment, pay, wherever possible, that's what we're going to continue to do. So let's keep moving forward.
And you're right about getting some of this stuff done fast. We're getting surrounded by Baptists. Baptists just got ordered Oakland today. So it's going to be Baptists that take steps. So they're on our northern flank. We have to watch the wall.
We are absolutely competitive areas.
South and north.
All right. Thank you again to the medical staff for the updates. Now we're going to turn to medical staff credentialing. Dr. Todd.
I have 2 months to report, so I'm going to start with the June report. The June report for credentialing is in your packet under tab 1A to 1D. For the month of June, the smaller packet, not the big one. For the month of June, system-wide, there was a total of 18 new physicians and 12 allied health professionals for initial appointment. There were a total of 104 physicians and 17 allied health professionals for reappointments that were recommended for approval. There were 54 voluntary resignations and there were 0 involuntary resignations. All appointments and reappointments were reviewed and approved by the C&Q committee and at the MEC at each facility in accordance with medical bylaws and rules and regulations. There were no reportable events to the National Physician Data Bank, and there were no outliers to the OIG or SANE exclusion reports. There is one error in the report at Coral Springs. Dr. Tatiana Garcia was inadvertently excluded from the report. She was voluntarily resigned due to lack of patient encounters. There were no encounters with this provider for the past 2 years. So she was voluntarily resigned as per the rules and regs and bylaws. This concludes the report for June. I'm requesting the report to be approved for the board. Any questions for the June report?
Are there questions on, that's just 4A or does that cover 4A through 4D?
That was 1A to 1D for the June packet. Do they have a June packet?
Yes, they do. You have the June packet. It's a little smaller, but it's also white.
Okay, are there questions on items 1A through 1B, which were deferred from the June board agenda? Hearing none, I'll entertain a motion to approve.
So moved.
Second. Any further discussion on the motion? All those in favor?
Aye.
Any opposed? Motion carries. Thank you, Dr. Todd. I guess now we turn to items 4A through 4D.
Yeah, this is the July credentials report. The details of the credentials report at all 4 facilities are in your packet in 4A and 4D. Here's a high-level summary. System-wide, there were 24 new positions and 8 allied health professionals for initial appointments. There are a total of 142 positions and 20 allied health professionals for reappointments. There were 33 voluntary resignations and 0 involuntary resignations. All appointments and reappointments were reviewed and approved by NEC and C&Q, and in accordance with members of bylaws and rules and regs. There were no reportable events to the National Physician Data Bank or any outliers in the OIG or state exclusion reports. There were also 33 core privileges conversions from Coral Springs. As you recall, in November 2017, this board has approved the new DOPs for core privileges. These core privileges were worked on for 18 months by department chairs and chiefs of staff at all 4 facilities. This is the standard practice per the Joint Commission standards. Core privileges are a set of privileges for certain specialties that all physicians or providers should have. The providers still have the opportunity to exclude any of those specific privileges and the core privileges. They can still opt out. But to maintain consistency of privileges for certain specialties, these are core privileges that all of them should have. There are special privileges that can also add to the core privileges, and these need to be requested specifically and approved by the department chair, C&Q, and NEC. So Coral Springs started. They have 33 core privileges for emergency medicine and 25 for internal medicine, and those are listed in your packet. For committee appointments, for July, Broward Health Medical Center added Dr. Dion Osnad and Dr. Katiana Brown Burgess to the OB Quality Management Committee. As you all know, any committee appointments needs to be approved by the board. This concludes my report. I'm requesting approval from the board for the July financial report. Any questions for July?
Are there questions concerning items 4A through 4D, the medical staff credentialing for July? Hearing none, is there a motion to approve?
So moved.
Second.
Any questions, any comment on the motion? All those in favor? Aye.
Aye.
Any opposed? Thank you, Dr. Todd.
Chairman, could I make a recommendation? If you're gonna do the walk-on item, if we could potentially do it now before the CEO update, because the Broward County General Counsel's here, but has to go. And in case you guys have questions, I wanted to make sure you had the opportunity.
Yes. We do have a walk-on item relative to the interlocal agreement regarding the City of Pompano Beach Community Redevelopment Agency. And I'd like to suggest that we add that as a walk-on item to the agenda for discussion at this point.
So moved.
Is there a second?
Second.
Any discussion? All those in favor? Aye. Any opposed? Thank you, Gino.
Thank you very much, Commissioner Klein.
There's a handout.
Yeah, so this handout is a settlement agreement that would have to be signed by the board, actually 4 original copies, were requested to be signed by the board. The CRA was established in October 1980 and has been in existence ever since. The funding for that is to the tune of about $7 million a year between the North Broward Hospital District, Broward County, and also one other entity, I believe, the Children's
Services Council.
Thank you, there it is. So our portion, just so you're aware, is approximately, it's been approximately between $900 and $1 million a year. It fluctuates depending on the tax rolls. But for the next, it sunset a few years ago, and there was an extension that would take it about 30 more years. The fiscal year 19 assessment rate for the North Broward Hospital District is approximately $1 million. So as it currently stands, it would be $1 million for the next 30 years. The settlement agreement, which all parties have signed, except for us so far, would, for the North Broward Hospital District, allow this to sunset, and it would be a total for the North Broward Hospital District over a 7-year period of $4.525 million. So it would be $1 million for 20, $1 million for 21, and then it drops to $750, and the final year is $275. So staff is making a recommendation that we be a party to the settlement and execute that agreement today.
And I understand there's some level of urgency associated with this request.
There is, the agreement has to be signed by August 15th, and that's due to statutory requirements, is that right? The fiscal year.
After 2025, how is the funding? I know we're out of it, but who's?
So after 2025, the TIF completely sunsets for all parties. So there will be no more funding coming to the CRA from anyone else.
You know, I read this last night when I saw it. I think we discussed earlier that upon our execution, all the parties executing it, all the litigation would stop, be withdrawn, and this lawsuit would be over.
That's correct.
So instead of us having the potential if we were to get that lawsuit, which we're not a party to, it caps our future obligations to $4.52 million.
Correct. So it's if the county were to lose the lawsuit, we would be locked in for another 30 years, which is about $1 million and ballooning up each year. This settles the agreement, cancels out the lawsuit, and our entire obligation would be that $4.5 million over 7 years, and then it sunsets indefinitely.
I know it's tough to predict the future, but, is there any possibility that even though this particular item sunsets, that one takes its place and we're somehow roped in? Or is there anything we can do to prevent that from happening, so that we're not exposing this board and future members of this board to further funding obligations relative to something like this?
So that's a good question. I asked that question, and Lynn had asked that question as well, and I think, if you don't mind, the Broward General Counsel will probably be best to answer that.
Thank you.
Certainly, Renee Herrick, Broward County Attorney's Office of Attorney.
Thank you.
We have written into the interlocal agreement, which all the parties would be executing, that this not only concludes all TIF obligations of all taxing authority for this entity, for the Northwest District of the CRA, but the CRA and the city would also be agreeing that they could not extend or expand without the prior written approval of Broward County. So CRAs are creations of statute or of delegation of authority. So unless the county were to authorize the creation of a new CRA or an expanded CRA, there would be no additional basis for this to come back.
But even if the county were to authorize such in the future, is there a way that we as the North Broward Hospital District can avoid being pulled into that? I mean, it seems to me this affected us, tangentially, and our obligation may not have been one directly undertaken. So, again, I think this is one aspect of this, concluding this phase of it, but I'm concerned about potential future phases. And what's the county's view with regard to how this might proceed in the future, to the extent you can anticipate that?
I can share that the county feels very strongly that CRAs had a purpose and served their purpose, and that the future funding of redevelopment efforts should be through an alternate structure. So Broward County has expressed to both this CRA and the others that are currently in existence that the goal is to redirect redevelopment efforts to a more cooperative effort through something like the kind of redevelopment program with alternate funding methods, non-TIF based.
But of course, that's subject to the county commissioners adopting, a different procedure in the future, a different process in the future.
Like this board, everything's based upon the will of the board. There is a statutory requirement for the creation of a new CRA, so there's a lot of legal hoops that need to get jumped through before a new one could get created. So if that never came before either Broward County Board or any of the taxing authorities.
How did this organization become obligated to this stream of payments? Was that something that the board of the hospital district agreed to or voted on, or was it something that was pushed on to us by the Broward County or some other?
It was a shared responsibility that was not initiated by this board. Under the statutory structure, Chapter 163 of the Florida statutes, the mechanism to create a CRA is primarily between the municipality at issue and the county, but it affects all of the taxing authorities for that regional area.
That's
Because we're
because we
taxing
are a
authority.
taxing district.
And obviously, the county's not going to agree to a permanent usurping of those powers. I would assume.
And if it helps, the Broward, the hospital district shares approximately $1 million a year, and the county share is upwards of $4 million a year for this Syria alone, for this district of Syria alone. So we
And
understand.
this has been, and that funding has been going on for how long?
1980, it was created, but the TIF actually began shortly thereafter. There was a period. So it was due to end its first 30 years in 2019. The CRA attempted to extend for 30 years. This is the resolution of that additional 30 years.
Okay, thank you.
Do you have it in front of you? Can you tell me what I'm reading on page 3 of 25, section 1.5? Is this something that occurred in the past, or is this something we're agreeing to? What is this referencing?
Maybe, so what this settlement, proposed settlement would do, currently your TIF is in place through December 31st, 2019. That would be the last TIF obligation of any of the participating tax authorities, the county, the hospital district, or Children's Services Council. However, the city would like to continue the CRA for its ongoing redevelopment efforts for that area, and this settlement allows the CRA to continue without any TIF obligations of any taxing authority other than the city. So 1.5, the extension period, I believe is your question, allows the CRA to continue through December 31st, 2040, but only funded by the payments that you see in the payment schedule in section 274 and by city TIF only.
But where does it, I see where it says the decrease, but where does it say in the definitions or in the terms that that's all we're on the hook for?
Sure, in section 2.7.4, or 2.7.1 is the hospital district funding, which references the chart in 274. And then if you refer to 210, it clarifies that there is no additional obligation by any taxing authority for any other indebtedness or obligation of the CRA, in any attempt to impose anything.
So at the heart of this was Pompano Beach's effort to continue to obligate the county and the district for developments in Pompano Beach.
Without any of our prior approval, correct?
Congratulations on getting this settled.
I think you had indicated that the county share is roughly 4 million,
I think you're correct.
and our share had been, under $1 million.
Between 900 and 1,000.
So why is it that, the payments going forward don't reflect that 4-to-1 ratio under this settlement?
Yeah, it doesn't actually reflect the perfect ratio, and we actually did the math. So, if you take all of the TIF obligations of the non-city TIF, we did the allocation between, Children's Services, Hospital District, and the county. County's approximately 74%, hospitals approximately 20, children's the remainder. If you project it out, technically, the hospital share should be 4.6 million, but, the county picked up a little bit of the extra, maybe, even numbers, so yours is right at 4.525 rather than 4.6. So it is a pro rata share of the TIF obligations for every taxing authority other than the city.
And we had, counsel representing us in this matter?
Yes. I mean, not in litigation, but to review the settlement agreement.
But this,
Outside counsel who specializes in this area and worked with Renee on the settlement agreement, well, reviewing the settlement agreement that was proposed.
all right, thank you, and, that attorney was not engaged in the negotiation of this settlement?
No, this was already done and signed by, all parties except the county, that it was presented as is. We had discussed, some of the concerns, Commissioner, that you had raised, and were comfortable that they were addressed in the existing agreement. However, there was opportunity to make additional changes that Renee was gonna make, but we found it in the agreement, that it covered it adequately.
So you're satisfied?
Outside counsel is satisfied, and I'm satisfied.
Has the community, the CRA, have they issued municipal bonds that they're expecting future debt service from these payments, or no?
Two-part answer to your question, sir. They have current bonds that are due to mature in 2019. They had indicated that they would like to bond based upon this payment stream and the city TIF. So my understanding, they do intend to issue additional bonds, and that's specifically addressed in section 2.10 of the agreement to indicate that if they do incur any additional indebtedness, that none of the taxing authorities are.
I'm still unclear as to how this breakdown was agreed to or set as between the county and the hospital district. You know, for year one of this, there's a 4-to-1 ratio. For year two, there's roughly a 2-to-1. And after that, the hospital district is paying more than the county through the next several years until the year 2025.
Sure, and I understand how it appears that way. Let me show you in 2.7.4, that funding schedule. What you're looking at is the total of the project funding. But if you look at the left column, second left column, the residential district funding, that $10 million, that is funded solely by the county. So the share that you see of the 4.5, the hospital district share, that is simply the hospital district share of the combined total of project funding and annual funding.
All right, so footnote 1 indicates that first residential district funding is the county's share as well.
Solely the county share. Plus, then the county also pays 7.5.
Right, so there's 2 columns that represent the county's contribution.
Correct.
Okay, totaling 17.525 million.
Correct.
Okay.
Have you seen this kind of a situation before in any other counties? Or you have just only Broward, you only looked at it in Broward County? You haven't seen this, is there a precedent for this in other parts of the state?
A precedent
For them extending, for the city trying to extend these CRAs and extend the obligation to the taxing authorities?
Sure, CRAs are a hotly debated issue on both sides of many policy issues. There have been pending legislation in Tallahassee to try and terminate CRAs.
Okay.
That's obviously a movement in support of CRAs as well.
So you haven't seen a case like this where, when they come to settlement and then the city sometime in the future goes back and tries to relitigate this?
I am not aware of any that is settled and resolved and then reopened. No, and this provides for specific enforcement. If there ever is a breach of contract, I try to mediate it.
Okay, thank you.
Well, I still have, I think, in the residential district funding, it says, the residential district funding is not paid to the CRA and is dispersed solely by the county. So it is being paid relative to this, but not necessarily as part of the share of this resolution. I think that there's 2 concerns that I have. One is that the breakdown of the numbers as between us and the other contributors, and whether we should have been engaged in this sooner and had a seat at the table if we're on the hook for millions of dollars. And 2, having our legislative affairs folks talk to the folks in Tallahassee to prevent something like this from happening again. Because if we're responsible for providing $300+ million of charity care every year, plus kicking into a development authority in Pompano Beach. Nothing against Pompano Beach, but I don't think that this is something that should be foisted upon us without coming out of our budget and being included in our budget actively. So I think this is rather offensive. But if it at the same time, if it eliminates some risk going forward and caps our exposure going forward, and the downside risk would be $30 million or so, then I think it leaves us with a tough choice. Other thoughts on this? And Gino, I guess the request would be that we authorize entry into this interlocal agreement.
Actually, no, this particular agreement would need to be executed by the board. Which is new to me, but, right, Lynn? That's what
I wouldn't see a signature page for us in there. Do you see one?
It's just, it's not the end. There are several signatures, there's one for each of the parties to the
That's not
settlement
what's going
agreement.
to see on.
Yeah, it's at on the left hand side. I'm sorry?
There's one for the chair side.
Chair.
Right.
I saw it.
It's page 14 of 25.
Yep. Chair or vice chair?
Either one, you can decide. You big man.
But do we first need to move?
I already wrote
Yes,
it.
vote on it? Yes. Well, I move that we approve the settlement agreement.
I'll second.
Is there a motion been made and seconded? Is there further discussion on the motion? I'll just ask General Counsel just whether the extent to which this particular document has been reviewed both internally and by external counsel.
Right, so yes, it's been internally reviewed by counsel, by Gino from the business side. I'm not sure if Alan did from the financial. I reviewed it, and outside counsel with expertise in the area did the substantial review.
Who's can we disclose to the outside counsel?
It's Kelly Kronberg, Irwin.
Kelly Crawford.
Irwin.
Just call me Irwin.
Blank on his last name.
I would suggest an amendment to the motion, to allow for either the chair or the vice chair to have a further conversation with outside counsel concerning the precise terms of this agreement prior to entry into or signature on the agreement. So authorization pursuant to that further discussion with our outside counsel. Since this is the first opportunity we're really having to review this agreement, I'm concerned, about each individual term in here. And if either Vice Chairman Yuri or myself are going to be executing this, I want to know that, I can have that discussion with outside counsel and have any further questions I have answered before I have to sign this. Chris has to sign.
Because this has to be done August 15th, right? Can we give him, can we vote yes and give him the authority to make necessary
I'll
changes?
call with them. To make necessary changes, I'm not sure.
Well, if they agree, obviously.
Yeah.
I mean, I don't want it to have to come back to this board.
Right.
Or it
So,
can't come back to this board.
Right.
It's
Not
timing.
enough time.
Yeah, that's why I want to give them the authority. Can we do it? Is my question.
Correct,
So it
the
would
authority
be-
subject to that further review.
Right, and if there are changes, then if they are not agreed to, then the board withdraws its approval.
The risk we run, I think, to my understanding, is we're not a party to this lawsuit.
We are not.
We don't really have a lot of say in the matter because we're not a party of it. If we don't execute this agreement by the 15th of August, and this settlement agreement were to go away, we then run the risk of the result of the lawsuit, which could be millions and millions of dollars additional capital to us. Is that correct? So,
It seems that,
that's my concern. I think that, we have an obligation we've been paying for 20 or 25 years at $1 million a year. It's an opportunity to execute this and be done with it for a little over $4.5 million, potentially saving us millions of dollars. I just would be careful about messing up the dates of this settlement agreement and getting past the county's requirement to get this closed, because that could, if it had to come back to this board, that wouldn't be till the end of August, and potentially past the date. Does that present a problem to the county?
The agreement specifically provides that if it's not signed by all parties by August 20th, the deal is void.
it's not unusual for a settlement agreement to have a drop dead date. What I'm suggesting is simply that we authorize entry into this agreement by either the chairman or the vice chairman, subject to that further discussion with council concerning the precise terms, to ensure there's a level of comfort with the terms of the agreement. And if there's none, then obviously the agreement gets signed. If there are, then perhaps there's a further discussion and revision, and if necessary, bringing back to the board. But I don't envision that being the case. I just don't want the board to say that either myself or Vice Chairman Yuri, who shall sign this agreement, not having an opportunity to read all every precise term on these 25 pages.
So do you need to amend the motion?
I accept your amendment.
Who seconded the motion?
I seconded it.
Do you accept the amendment?
Yes.
Okay, so the motion has been made and seconded and amended. Is there any further discussion on the motion? If not, all those in favor?
Aye.
Any opposed? The motion carries. Thank you very much. All right, the next item is the President and CEO update, Beverly Capasso.
Thank you. Now for the cheerful report, I apologize, but it is going to be a little lengthy, but I'm very proud of all the accomplishments we had here at Broward Health, so please indulge me. I'm pleased to report we've had several recent achievements and events throughout our healthcare system. It's been a very busy summer here at Broward Health. We continue to meet the healthcare needs of our community by remaining focused on our mission of providing high-quality care and outreach to all we serve, while lessening our dependence on taxpayer subsidy. Commissioner Gregoire and I recently had an opportunity to attend the Brightest Stars Awards ceremony. We had a really good time at Broward North. 6 honorees were selected for being outstanding examples of what Broward Health's 5-star values and for demonstrating individual acts of heroism, courage, kindness, and generosity. And we were overwhelmed with the stories. It was amazing. It just was an honor for us to be there and to present to these outstanding employees. They truly are making a difference. I go to these hospitals, I talk to the patients, it energizes me. I know Commissioner Vergara, you and I were both, it was an amazing
They are
event.
amazing people, and they're so committed to doing the best job they can for the people of Broward County. I was really, really impressed. At one point, we were crying.
Yes, the stories
I was
of
sad to miss out. I've attended them in the past, and they are really moving.
the stories, you'd be so pleased and honored to see what our employees, what they do. This year, this summer also, we welcomed our 2018 internship class. For the past several weeks, we had 22 outstanding college students who work closely with leaders throughout the healthcare system in various locations, finance, general counsel, risk management. I have every confidence that our 2018 summer interns will be among a dynamic group of leaders who will shape our future workforce and make a positive impact on the healthcare industry. Actually did a CEO roundtable with them. They're from universities from up and down the coast, and they were asking some great questions. Again, it was well done for all of the mentorships and the partnerships you did with our interns, and I see there's a few in the audience too. And we also have hired on a few, so we are recruiting the best and the brightest for sure. I'd also like to share, and I don't see Anna here, Children's Diagnostic Treatment Center, CDTC, they recently celebrated their 35th anniversary. We have served more than 11,000 children with special health care needs, and that's another place. I know Commissioner Wellens, you sit on the board there, and the good work they do there is amazing. I'm also pleased, and I know that Dr. Jensen discussed it as well as Dr. Zingaro, that we had a very successful joint commission surveys throughout our health system. All 4 hospitals did spectacular. Thank you to the CEOs, the CNOs, and the team. Our teams were just amazing, and we had the same lead surveyor, and throughout the entire 4 visits, continuously said what a great group of employees. Your nurses, your doctors, everyone is so committed to high quality, patient-centered care. So kudos to all our hospitals. Broward Health Medical Center cardiac medical intervention, rhythm and surgery programs also received an Aetna Institute of Quality designation, showing excellence in care and commitment. The Department of Health recently conducted a quality assurance survey for the perinatal for high-risk women. We also received very high marks for that. And our emergency department nurses, and being an old ER nurse, this was actually another very cool event. They put their life-saving skills to the test during the First Dare First Care Conference. This was a collaboration between EMS and nurses throughout Broward County. Our teams at Broward Health Medical Center and North did an amazing job, and we placed 2nd and 3rd respectively. Next year we know we're going for the gold. Again, on our people pillar, we continue to recruit highly qualified talent into our system to support our mission. Michael Cavazos, who recently joined Broward Health, is here from Tenet Healthcare. Michael will serve as the new corporate director of claims and insurance services and oversee internal and external claims management, loss control, and prevention programs. He's working with Lee Gezi and his team. Kim Braxel Cole joined Broward Health North as our Chief Financial Officer. She'll work closely with the leadership team to further cultivate an environment of operational efficiency and strong financial results. Just 20 years and came to us most recently from Delray Medical Center. And last but not least, and I know this gentleman sitting next to me is very excited, we will have a new Chief Information Officer, Kathy Ross, who'll be starting on July 30th. In her role, she will provide leadership, strategic direction, evaluation of all IT, and services to enhance our healthcare system delivery. She came to us through Stony Brook Medicine in Stony Brook, New York. And also I would like, and I don't see him here, but want to give a shout out to Jonathan Watkins, Imperial Point CEO. He was recently recognized by the American College of Healthcare Executives with their Service Award. Jonathan exemplifies what makes Broward Health such an incredible health system. So as far as growth, I know Dr. Zingaro talked about the new tower. We invite the public to please come and join us for the ribbon cutting that will take place. It is August 16th at 5:30. Broward Health Coral Springs, we also had an opening of their interventional lab that was on Thursday, June 7th. And proud to be the first and only hospital in Florida to have installed the Sky Plus interventional lab. As far as community outreach, during the months of May and June, we had a total of over 1,000 community events, again, touching over 59,000 lives. Also, Broward Health North hosted an interfaith prayer breakfast with the Southern Christian Leadership Conference of South Florida. It was truly an inspirational morning. Vice Chairman Yuri attended with me, as did Alice Taylor. We met with other faith-based leaders to discuss how we can work together, the betterment of our community. We also were going to be, I think it was Reverend Johnson had suggested that we go to the different hospitals for the meetings, which I thought was a great idea. Then they'll get to showcase the hospitals and meet the CEOs. It was a pretty good day all around. And lastly, a little financial and operational review. I know we've been mentioning this, but I am especially pleased to share some of the significant financial and operational achievements we have made. Since last August, we have saved over $34 million through contract renegotiations, operational improvements, and reduction in our contract labor costs. Also, that we have reviewed the assets owned by our hospital district, and we'll be identifying those parcels of land for sale that will also help us lower our taxpayer burden. We've hired a forensic accountant to investigate and report on how the hospital came to acquire numerous parcels of vacant land over the past decade, especially when we're going to be selling. We want to make sure that we look through it all. There's some obviously that we need, but and I'll report back. I know Gino and I have been working, and we'll report back on that. In closing, I am deeply grateful to the entire Broward Health team, our medical staff, and this Board of Commissioners for their support of our mission. Thank you.
Thank you, Beverly. That concludes the CO report. I just want to mention, you mentioned that piece of equipment at Broward Health, Coral Springs, which I mentioned earlier as well. I understand there was an operation yesterday that wouldn't have been able to have been done but for that equipment. So it's great to hear that. And again, thanks, Jared, for all you're doing over there. You're obviously in a very competitive area, but very hands-on and responsive, so thank you. And John Watkins, you mentioned as well. I had the opportunity to stop by one of the last town halls that he held at Broward Health Imperial Point, and really did a great job speaking to his staff. They seem to be very responsive. Gave me a couple of minutes to say hello and share a few words on what's going on at the board level. So
And they loved it as much as they love seeing the three of us, and we're all over. They especially love having the commissioners stop in. The staff talks about it. I'll frequently go and say, hey, you know who we saw? And they were really impressed. So again, thank you for that. They love seeing you.
That's great. Glad to hear it. And I think it's something. Well, I'm happy to do it. It was between two other events. I was able to squeeze it in. So really glad that I had that opportunity. And it's just great to be able to speak to the people who are providing the care and talking to them directly. So it's a great opportunity. I don't know if that's something the other hospitals are going to be doing, but certainly if they are, please let us know if they're having any of those open houses, and we'll obviously try to cover some of those as well. Next item on the agenda are two items are demonstrations, one of the teletracking system and one of the Da Vinci robot. I'll turn to Alan. Do you know on that?
We have someone here from Teletrack. It's going to be. This is what, just to recall, the board asked for just a quick overview of what this teletracking patient flow system that we're bringing in is, and how does it work, and what does it look like. So.
Good evening, ladies and gentlemen. Board, thank you for having me.
Thank you.
Really appreciate it. Actually, we're very excited. I was sitting here listening, and all the things that you're doing, you're working on, the stroke program, the cardiac program, the neuro programs, all the new equipment that you have, and talking about the new board. And this initiative, it's actually something that, working together from your executive leadership team, that we're very, very excited about. And if you go to the second page, normally I do this with a projector, so my apologies there. But our mission with teletracking very much aligns exactly with your mission. And the leadership team reached out to us because they don't want people to wait for care. You have patients that come into the emergency department, you have patients in the outside that need your help, to have your care. How do we get there? Which hospital do we put them in? How do we get them there in the most efficient manner? So they were looking for data, they were looking for all these things. And the challenge was, we have to have all these tools to help get our patients in quickly. We need to understand what's there. So with that said, the next slide just basically kind of runs over a brief overview from end-to-end care. So how do you get people from the home to your organization and back home in an efficient manner? Because that's going to do one thing. It's going to focus on your patients, how to give them great care, and how to keep them happy, improve your HCAP scores, so they want to return back to the organization again. So talking about New Broward, it is very much a new program. They're actually dedicated to understanding what's happening. And across the bottom, we're going to align with the team on best practices, workflow automation, allowing people to have analytics so they can look at what's breaking down and how do we fix things. And most importantly, we're going to be able to push information out to the caregivers and the physicians so they'll have the data that they need to make the choices. So when you're away from something, you can get notified. Hey, I need to take a look at something. We're breaking down along the way. So, talking about cutting edge, you guys are the hottest thing in this arena right now is command centers. So you hear about command centers a lot, especially in emergency services. You hear about command centers, and you think about it, what are they trying to do? They're trying to take people and get them quickly taken care of by the way of, if it's a fire, if it's a whatever it may be. And you're going to treat every patient as if it's an emergency. One call from a physician from an outlying hospital to one person will come in through the command center. They'll pick up the call, they'll answer the call, and they'll say, yes, we'll get you to any one of your hospitals. So no longer is it going to be treated at this hospital, this hospital, and this hospital. Now these folks will have to have visibility across every single bed. So a lot of people like to think of it as air traffic control. Currently, when you call, well, you have to call a hospital, and you have to go through the process, and it's a paper trail and everything else. No longer are they going to be able to do that. Now it's going to be one call. There's a process set in place. They'll reach out to the physicians. They'll get acceptance. Upon that, when the patient hits the door, you'll have registration in this area. You'll also have utilization review and case management. So they'll have a look at the patient, understanding who's coming. And then from there, by the time that patient arrives, they'll already have the bed assigned to them. So it's very, very efficient as it works through. It doesn't matter if you're using helicopters, ambulances, or people are driving in. It's a way of getting your folks in. Now, across the bottom, I mentioned a couple of things that are very, very important for these gentlemen over here. And that is number one, transparency, because they cannot manage something if they can't see it. So what this does is not like an EMR at all. This actually takes the information that you need from various facets, brings it together, and opens up to say, what do we need to do to care for this patient? What is their care path? Now, it's not all of the things behind it. It's what needs to happen next to move this patient. So if you've ever been to an emergency department, you've gone in, they see you, and then you sit there for hours. These are the kind of things that we want to stop from happening. Get these people up to the floor, and once they get there, get them treated quickly, and then able to get them home quickly. So everybody benefits. What we're going to do by this transparency is also give the nurses more time to spend time with their patients, because they're not chasing phone calls back and forth. And the backside of this is not just something you know put in and leave. So I wish I could have put this up for you to see. But what you're looking at is you're seeing a series of folks sitting in a room. Basically, it looks like NASA. Everybody says. So what you have is in the front, you have all the metrics of all the hospitals where they're at. In front of them are the screens of where are beds available. Where can we put our patients? So you guys have done a great job in working through this. And as a matter of fact, as far as command centers go, you did it very efficiently and very effectively. So going down the road, these folks have had the ability to work with some of our key players in the past. And we're going to bring some of our best experts in that are literally leading the country in what they're doing to work with them. So this is not just put it in and leave it. This is a continuous improvement event. So take what's broke, fix it, continue the process moving forward. So if you look at it, the outcomes that I mentioned there, what you're talking about, if you decrease left without being seen. What happens is most of the time in hospitals, you can't get them in because you can't get them out. So you have to work very, very diligently on the back end to create capacity on the front end. And so it's like a pipe. You put a plug on the end, you can't fill it with water anymore. So what we want to do is make sure we pull the cork off and the water flows and your patients are able to get in quickly. So you want to reduce their movings around and you want to reduce their time from the discharge. Physician writes the discharge, doctor says they're ready to go, let's get them going. Let's get them back to their home where they want to be in the first place. And so work through the process. So the next thing, I just wanted to mention a couple of things. When you start looking at the back end, we're going to have some programs. We're going to work together with y'all. What's your discharge process? How can we help with that? What's your intake process? How can we help with that? So once this is actually begins, the software is in place and all the data is there, now you can look at how do we fix it. So once the problems are identified, then we can actually set up strategic goals with y'all to get you to where you need to be. And last, I just put this here because it is always a work in motion, because just the time you think things get going good, something happens, people leave, adjustments. So once again, it's a continuous process. But I think if you look now, the challenges that were brought to us is that they don't have data, they don't have transparency, they didn't know exactly how to improve things. So y'all are probably somewhere in the one space right now, which is somewhere I think you'll be off of very soon, because next year we believe you'll be in the 4 or 5, and there's very, very, very few hospitals in the 5 zone. Being able to look ahead, being able to predict and understand, but it's all about data and it's all about process, and that's where we want to work with the team, which we are very excited. As a matter of fact, I hope we get invited back next year and a year from now, because we are highly confident that this group will surpass. I think you're going to see the change, because when patients get in quickly and they're treated well, it makes everybody happy. So with that, are there any questions?
Where will this be, this facility? Will it be in this complex or in the hospitals or each hospital?
Your command center is located, it's a one facility, it's one room, as you saw there. And it is located.
It's in our ISC building, which is located across the street from the medical center.
So imagine from that one room, they can see every bed in every, so if you have a child that needs help, if you need a neuro patient that needs help, they'll be able to see the availabilities. And here's the beauty of it too. So let's say you get capacity in one hospital, you're busting at the seams. It happens often. So what do? Well, yes, we'll take you. We're going to take you to this hospital. And you know it right off the bat. You don't have to sit there and make a bunch of phone calls around. So the other thing seen is when people call to get care, and I'm talking about referring facilities, when you say yes quickly, we can take them, and here's where they're going, guess what they do? They call you back the next time, because people, they want the easiest way in. So if I call you and you say yes, we can take them, come on. So,
I like this because it makes us a system versus silos, individual hospitals, but I don't see anything about revenue cycle, financial clearance, insurance verification. Is there any of that involved in this?
Yes, sir, on the front end, they're gonna have, all that's part of the acceptance process. So when that's part of your process internally.
Yeah, not within this platform, but it's part of the process of accepting.
So those folks that are verifying and validating insurance, those folks that are in office and financial clearance, they won't be sitting there, but they will be part of the process.
Correct.
Integrated into it.
Yes.
And Janice Mitchell knows that?
Oh, yeah.
Okay.
Yeah.
Right, it's actually in her office.
Okay.
Yeah, it's literally right next to her office.
Good.
One small benefit, which is actually quite a large benefit, the quicker you move patients through, obviously there's reward. So if you can reduce the length of stay, the cost burden goes down for treating the patient on a reimbursement level. And or it gives you the capacity to bring another person in quicker.
And you'll be working on our legacy system? Our system, Cerner.
Yeah, so teletracking actually integrates pretty well with Cerner, luckily.
So the last thing we want to do is bring in an efficient program that's going to make people double document, so people are going to be working through their natural process. So when they're entering data in, it's picking that data. And more or less, let me give you a simple example. It's like you walk into a library and there's all this information around you. Do you want a cheat sheet? Or do you want to go find your information? And what this does is it gives you the cheat sheet. It breaks all the data points, and each hospital will be able to select what information they want to see in order to estimation.
What's the calendar for this?
You begin August.
We go live August 6th for the transfer center, which is gonna be the ISC, and then we have some subsequent timelines to roll out at the different facilities, different modules.
And you have the trained employees already?
Oh, yeah.
What you're looking at is actually a picture of your command center with the patient, with your team going through training. That is yours.
Gotta look again.
That's why I wish I had a
I thought
screen.
you photoshopped a logo on there.
Yeah, I wish I could have had it up on a screen because you could have had a much better view of it, but it's actually beautiful. They did a great job. They provided stations that raise and lower, so people are there for long periods of time looking at the screen. They can stand up, sit down, and be comfortable as they're taking care of your patients.
And who's responsible for redundancy, both in terms of communications and power? Is that us, or is that?
So interestingly, I think we're the first center, correct me if I'm wrong, Michael, in teletracking that actually has fully 100% redundant networks for our system. So the chances of this going down is very slim, but the facilities, of course, always have their downtime procedures.
Some of the greatest
So
things
we're responsible.
we're seeing with this, and people really do enjoy, is hurricanes, because you have to evacuate hospitals. So it's very easy to turn it over to the command center. They start moving those people, they're starting to move, they move people to availability. So people in the low-lying areas, we see that a lot in Florida, where people want to remove those folks from the area.
Do we have a backup power provision there?
Yeah, the ISC building would actually really shock me because we have multiple levels of redundancy on every system there. We have, a system for the fire that sucks the air out of it to make sure we don't have water damage. There's generators. It's pretty impressive. Which is, by the way, why we chose to stick it in the ISC. We were originally going to stick it here, but because of that reason, we put it there. Yeah, the whole IT network is there. Everything is there.
Okay, so it's set up for a hurricane type event.
Yeah, that's where our command center is. The building is hardened, so it's.
And what about our information backup? Is there offsite backup for the information that we have?
Offsite backup. Thank you, Mike.
This last page, this continuous improvement.
Yes, ma'am.
Is stage, where are we in these stages?
Right now, you're in the stage one.
Stage one.
So there's not a lot of information, there's just, and so what we.
I
I don't like to say that to anybody, but there's a lot of it out there that folks just don't have the data, they don't understand. It's all, there's a lot of hearsay on what's happening. So in order to make good decisions, you need a lot of information behind it. So what we've done is we worked with their team, created benchmarks so we understand where we're starting. We've been given a lot of direction, so they want to get folks in quickly. They want to reduce left without being seen. They want to be able to provide everybody that level of care that they deserve. And most importantly, they want to improve their throughput and get folks out once they've been treated, and the physician says it's time to go home to effectively do that.
And what's the maturity timeline stage? I'm sure that depends on the facility, but what's your experience on average?
My experience is we've got a great number of clients, and we have a lot of very, very efficient clients in this southeast area. And there's one key thing that we see with every successful client, and that is a strong leadership team. And your leadership team has done a phenomenal job bringing together all the leadership from all of the hospitals, and sit down and establish goals, metrics of where they expect them to be. I couldn't tell you this with any other hospital, but I could tell you within a year I expect you to be at 3 or 4, which is monumental. So people will be calling you wanting to know what you're doing and how you're doing it. I feel confident in that because it's a leadership team, and it's really a top-down thing. It's like we're doing this for the right reasons. The side effect, though, from all of this, more throughput, it does help the revenue substantially. So I know
Just
that.
answered Commissioner Barry's unasked question.
Yeah, I'm gonna look at that all the time. Should help.
All right, is there anything further on this item? I think to me, it just shows another area of improvement. I mean, the last slide says continuous improvement. I think that relates to this system as well as our system, so.
It's an ongoing process, and you're doing a great job, and not just sitting here listening. It's been a real pleasure, so thank you for having us.
Thank you, sir.
I just wanted to thank Michael Humphrey. He's really been running this from the corporate side.
Where's Michael?
Michael's back.
sure it all works.
Don't screw it up.
No pressure. The next item is the Da Vinci robot demo, which I think involves a little field trip for us.
It does, so, we're gonna go next door. I didn't know if you wanted to hear anything about it from, the Intuitive. Jody's here from Intuitive, and we have it set next door, so.
So why don't we do that? Why don't we get a,
It would be hard for her to take notes. You want me to go?
that would be necessary.
If everyone agrees just not to talk.
Bring Dan's camera. Bring Dan's camera.
Do you not have portable power?
I'll take myself over there, I just don't think I'd want it all on the.
We're all together, I think we should, so.
Yeah.
Okay, so.
Sir, you want to spend a minute giving us an overview of what we're going to see, and for those who don't know what Da Vinci is?
Yes, good afternoon, everyone. Jody Zachowicz from Intuitive Surgical. Thanks for having us here today. We're excited to be here. We've been partnered with you guys for over a decade now with launching robotics programs within Broward Health. So we're excited to look into furthering that partnership with you guys. You guys are going to go get a chance to see the Da Vinci XI system, which is our flagship robot. We specialize in minimally invasive surgery. It gives surgeons the autonomy to control the surgical platform by sitting in a surgeon console and performing surgery. So the specialties we're currently involved in within Broward Health are urology, gynecology, gynecologic oncology, thoracic surgery, general surgery, colorectal surgery, and those specialties continue to expand. So we're excited to be here today and look forward to kind of giving you guys a nice hands-on demo of the platform itself.
Looking forward to it. We've heard great things about it. Surgeons that I've spoken with, are just rave about robotic surgery in general and Da Vinci in particular, both in terms of being more comfortable to work through it, in terms of surgery, quicker patient discharge times because it's less invasive. So all around, it's a great improvement. So we look forward to seeing it. Are there any questions before we go and do the demonstration? All right. Do we need anything on the record with regard to us moving to the location?
I think, yeah, just to note that we're moving over there.
Okay, so just to note for the record that the board will be
The receiving area is where it is.
relocate the receiving area to view the Da Vinci robot demonstration. All right.
Looking forward to it.
Go and talk until she starts set up, okay?